The high demand for refractive surgery, with excellent results for myopia and low to moderate hyperopia, has prompted a strong urge for spectacle independence after these patients develop presbyopia and cataract. The several excellent existing IOL choices become a challenge when the surgeon faces a patient with previous refractive surgery and have to take into account the characteristics of the individual patient's eye. Surgeons might be reluctant to implant aspheric multifocal or EDOF lenses in these patients, as seen in the Society's prolific Eye Connect. In this video, we will present an unusual case of panfocal IOL implantation after previous hyperopic Lasik. The patient is a 63-year-old white female who presented complaining of bilateral decreased visual acuity due to a 2+ cortical cataract in both eyes. Past medical history was significant for previous hyperopic Lasik done elsewhere, controlled hypertension, and the use of trazodone. After routine preoperative evaluation, ocular surface and macular health were found to be within normal limits. After thorough discussion, the patient demonstrated high desire for spectacle independence, and the panfocal Acrisoft IQ Panoptix IOL was recommended. This IOL has all the features of the classical IQ family, with an optical zone composed of a diffractive structure in the central 4.5 mm portion, consisting of 15 diffractive zones and an outer refractive annulus. The panfocal uses quadrifocal technology, with 3 focal points at 40, 60, and 120 centimeters, plus the distance focus from the base curve. This technology was modified so that the extended intermediate focal point, 120 centimeters, is redistributed to the distance focal point to optimize light use, enlightened optical technology. As a consequence, the panfocal has a quadrifocal design with a trifocal function for the patient at far, 60 centimeters plus 2.17 diopter, and at 40 centimeters plus 3.25 diopter distance. Light is distributed 50% for far distance, with 25% each for near focus and intermediate focus. It transmits 88% of light to the retina with a simulated 3 mm pupil. Although the cataract must be taken into account, the preoperative NIDEC OPD scan displayed a 0.547 microns of HO-RMS and a 0.015 microns of spherical aberration, and a total of 0.447 microns of total coma as seen on the screen. On the other hand, there was no significant astigmatism. Note the typical topographic pattern of hyperopic ablation. It's widely known that H-Lasik induces negative spherical aberration and an increase in HOAs, making the IQ lens family with its minus 0.20 microns of SA relatively contraindicated. Previous reports of spherical multifocal implantation and aspheric multifocal implantation after hyperopic laser treatment showed good visual acuity and high overall patient satisfaction with their visual quality. After further discussion with the patient, we've decided to proceed with the implantation after using the Asker's post-refractive online calculator. The surgery was uneventful and a CTR was also implanted, as we routinely do for multifocal IOLs. 3 months post-operative slit lamp examination shown here display a perfect center IOL, and some degree of anterior capsular rim opacification. The patient was thrilled with her vision. Uncorrected distant visual acuity of 20/25, J1 for near, and a spectacle independence. To our surprise, the postoperative OPD scan displayed a decrease in HORMS, 0.174 microns, a slight increase in the spherical aberration, and a significant decrease in the coma values, as seen on the screen. It's worth mentioning the final refraction or spherical equivalent close to plano, which is one of the major components in the final vision quality. Note the point spread function difference before and after. Further studies are necessary to verify whether this new panfocal IOL technology is a suitable option in optically demanding cases, such as in post-H Lasik refractive surgery, using aberrometry as an invaluable tool. Studies have shown that anterior corneal coma values of 0.32 microns may result in intolerable dysphotopsia in the presence of a diffractive multifocal IOL. This case is a shining example that there are wide variations on this theme, depending on the magnitude of the change in the spherical equivalent by refractive surgery and the uniformity of the change. The invaluable work of Dr. Douglas Coe group has demonstrated that some residual defocus or astigmatism combined with spherical aberration may produce different outcomes depending on the balance between lower order aberrations and high order aberrations. Of course, this is just one case, but it serves to point out what the distinguished Dr. Warren Hill states. Each patient is unique and individual. The fundamental problem with unusual aberration profile is a loss of contrast sensitivity. What makes it difficult to quantify is the fact that different aberrations reduce contrast in different ways, and some are better tolerated than others. Thank you very much for your kind attention.